Welcome, everybody. Welcome to yet another webinar of the European Stroke Organization, ESO, on a new set of treatment guidelines. My name is Martin Dichkans. I'm the president of the European Stroke Organization, and I'm here with Simona Sacco from the University of L'Aquila, Italy, and co-chair of the ESO Guideline Board. So the two of us will be leading you through this session. We are very excited to present two major guidelines and expedited recommendations, which will be officially released parallel to this webinar. One will be the ESO guideline on mobile stroke unit care in acute stroke management. And the second one will be an ESO ESMINT expedited recommendation on intravenous thrombolysis before mechanical thrombectomy in patients with acute ischemic stroke. Accompanying these patients, Accompanying these presentations, there will be two background talks by internationally renowned experts. Both guidelines will be made publicly available at the ESJ website starting from 6:30 p.m. Central European Time. They will be further published in parallel by the European Stroke Journal and through Magic App. For your interest, the presenters have already agreed to make all their slides available for download via the directory of the ESO guidelines, so please check this out later on. Before we start, let me thank all the guideline working groups for their enormous efforts over the last months. Getting the guidelines to this point required an enormous discipline and collaborative spirit. So thanks also to the reviewers and editors of the ESJ for working towards this particular timeline. A big thank you also to Guillaume Turc and Simona Sacco, chairs of the ESO Guideline Board, the guideline working groups, and Ivona Brüchert, our guideline manager, and of course, all the other people involved, and there are many. Simona will add here. So over to you, Simona.
Thank you. Thanks, Martin. Thanks a lot. It's really my pleasure to be here with you and to chair this webinar. I also welcome everyone who is joining us. We have really an exciting afternoon or morning, depending where you are, ahead of us. We have two guidelines and two keynote presentations. The lectures will be one after the other, and we will have time to answer questions at the end of the session. The questions can be asked by using the Q&A function. So now we can really start, and it's my pleasure to introduce the guideline on mobile stroke unit. This is really a new and a hot topic. The presenter is Silke Walter, who chaired the working group. Silke is a consultant neurologist at Saarland University in Germany. She has an extensive expertise in stroke management and pre-hospital stroke treatment, and she was involved in the implementation of the first mobile stroke unit ambulance in 2008. And she has been actively working in this field since then. So please, Silke, the platform is yours.
Thank you very much for this kind introduction. It is my very great honor today to present the very first ESO guideline on mobile stroke unit pre-hospital management. Next slide, please. Next, thank you. Our working group comprised 8 members, of whom 3 are actively working with MSUs at the moment. Next slide, please. This active MSU work, together with all other disclosures, can also be found in the supplementary table 1 of our guideline publication. Next slide, please. What are mobile stroke units? Well, can they make anything better for our stroke units? That's the overall questions we all have to ask. Well, they are ambulances equipped with a CT scanner, laboratory unit, and telemedicine connection to hospital. And they are staffed with stroke specialized teams. This concept was first described in 2003 by Klaus Fassbender, who had his first MSU on the road in 2008. There are multiple publications indicating a benefit coming from MSU care, and I've only listed some of them on this slide. This encouraged ESO and us to analyze the evidence available in a guideline project. Next slide, please. This slide shall just give you an idea of how these ambulances look like before we move on to the guideline details. They all look a bit different depending on where they are located. And this is important because they all have to be integrated into different health systems. They have to adjust to the local system in which they operate. Next slide, please. In this guideline project, we follow the ESO standard operating procedure for guidelines and the GRADE methodology. We formulated 3 Pico questions with 3 different populations, and you can see them in the small table on the right-hand side of the slide. Patients with suspected stroke, those to whom these ambulances get dispatched, patients with acute ischemic stroke and acute intracerebral hemorrhage. We identified 14 outcomes of interest on clinical results, and they were safety, the overall functional result of the patient, and patient management. We included randomized controlled trials, RCTs, and observational studies. And in case we found overlapping populations reported in the publications, data got disentangled. Next slide, please. Our outcomes of interest for the different populations were rated following the Delphi approach, and you can see this on the left-hand side of this slide. We considered safety outcomes as most important for patients with suspected stroke. Clinical outcomes, treatment management aspects, and mortality were considered as most important for confirmed stroke patients and for patients with hemorrhagic stroke. We conducted 23 sets of analysis and another 3 sets for a pre-specified sensitivity analysis, in which we included the only 2 observational studies which assessed the clinical outcome at 90 days in a blind manner. That was Be Proud and Best MSU. Next slide, please. We concluded our results in only 1 combined recommendation. We decided that this very unconventional way is necessary to reflect the way of operation of an ambulance. Because at the time of dispatch of MSUs, so at the time the intervention is applied, the diagnosis of the patient is still completely unclear. And it would not be feasible to dispatch a MSU to, for example, acute ischemic stroke patients only. This is why we combined it all to 1 recommendation to reflect real life, more or less. Next slide, please. With our first Pico question, we address the population of suspected stroke patients. They are the whole population to which these ambulances get dispatched. You can see the forest plots for the safety outcome, all-cause mortality within 7 and 90 days on this slide, 7 days left-hand side and 90 days right-hand side of the slide. We could not detect any difference in the mortality between patients treated with MSU compared to conventional pathway. However, quality of evidence for this overall patient population was low and very low. And for 90 days, this outcome came from 1 non-randomized study only. We could not identify enough information to analyze any other outcomes. Next slide, please. Our patient population with confirmed acute ischemic stroke, our second Pico population, and we defined confirmed as hospital confirmed diagnosis, we found that patients treated with a MSU have a higher odds ratio for an excellent clinical outcome, and this is a modified ranking score between 0 and 1, and the odds ratio was 1.37, favoring MSU care. Next slide, please. We found similar results for a good clinical outcome, which is modified ranking score between 0 and 2. The odds ratio here was 1.23. And for any better functional outcome at 90 days, this is the modified ranking shift analysis with an odds ratio of 1.28. Sorry. The information for functional outcome analysis came from 4 respective 5 non-randomized studies, and to better understand the likelihood of these results, we performed an additional sensitivity analysis, and this was pre-specified. Next slide, please. In this sensitivity analysis, the studies Be Proud and Best MSU only were analyzed. Both studies were large, prospective studies with the modified ranking clinical result as primary endpoint, and this primary endpoint was assessed in a blind fashion. Best MSU had alternating MSU and control weeks, which we considered as quasi-randomized. And this analysis confirmed the results for functional outcomes. Patients treated with a MSU had a higher odds ratio of 1.46 to have an excellent clinical outcome. Next slide, please. And odds ratios of 1.33 and 1.39 for a good or any better functional outcome. Next slide, please. The proportion of ischemic stroke patients receiving intravenous thrombolysis IVT was higher in the MSU group with an odds ratio of 2.28, and more thrombolyzed patients received their treatment within the so-called golden hour, the first 60 minutes after symptom onset, when probability of full recovery is highest. The odds ratio here was 7.3. MSU treatment was associated with a shorter time between emergency call and start of IVT. The evidence for these results came from 1, respective 3 randomized controlled trials and 4 to 6 non-randomized studies. Next slide, please. In the subgroup of patients with large vessel occlusion stroke, we could identify a larger proportion of patients primarily transported to thrombectomy centers in the MSU group with an odds ratio of 4.3. However, we could not detect any difference in time to groin puncture or proportion of patients receiving thrombectomy. Next slide, please. There was no signal of any harm caused to acute ischemic stroke patients when treated with a MSU compared to standard care. You can see here the forest plots for the 90-day all-cause mortality on the left-hand side and for symptomatic ICH among those with IVT treatment on the right-hand side. We could not detect any difference in the outcomes of major extracranial bleeding and 7-day mortality or in the proportion of stroke mimics receiving IVT among all thrombolyzed patients. Next slide, please. Our third Pico question addressed patients with intracerebral hemorrhage. We could identify an increased proportion of patients primarily transported to tertiary care stroke centers in the MSU treated group. This was with an odds ratio of 6.44. Next slide, please. We could not find any association of MSU care with 7 or 90-day all-cause mortality, and there was not enough data available to analyze the outcome hematoma expansion. Next slide, please. We did not find enough evidence to analyze clinical outcomes for patients with ICH either. Therefore, we summarized our opinion in an expert consensus statement. We believe that the optimized management of ICH patients with direct transport to tertiary care stroke centers is crucial for their further treatment. And 4 members of our group voted for this statement and 2 against. Next slide, please. As introduced, we combined all gained results to one overall recommendation for this MSU management pathway, and this is: we suggest MSU care over conventional care, and there are 3 reasons for this. Firstly, in patients with acute ischemic stroke, we have moderate evidence showing an improved clinical outcome and optimized disease management, resulting in more and earlier thrombolysis without any increase of any risk. Next slide, please. Secondly, in patients with ICH, more patients get directly transported to tertiary care stroke centers. And thirdly, for all other patients, we could not detect any signal of harm. Next slide, please. However, we believe that specialist neurological expertise is essential for this care. We've summarized this opinion in a second expert statement in this guideline document. This specialist expertise can be provided either by an in-person expert or remote consultation. All members have unanimously voted for this statement. Next slide, please. To conclude, there are many new things going on in the pre-hospital stroke field. We were able to develop a recommendation with the results available suggesting pre-hospital management of stroke patients. But definitely further research is needed, especially on dispatch accuracy, on the question of how beneficial this management is in different geographical areas, for example, in rural areas, and how cost effective it is. Identification of probably novel diagnostic equipment might help to facilitate an implementation. And there are already ongoing and new future studies which will lead to further information, especially regarding acute treatments and the cost questions. And with this, I would like to thank you for your attention.
Well, yes, thank you so much, Silke, for sharing the results of this working group. And thanks again also to the entire working group for their efforts in making this possible. Very important results, very important to see this being published today in the ESO guideline. I would like to remind everybody that there is an opportunity to submit questions through the chat, and those will be picked up by the moderators and asked later on to the speakers. So please don't hesitate to ask questions. Meanwhile, we should now proceed to the next presentation, and this will be given by Heinrich Audebert. So it's a pleasure to introduce Heiner, Deputy Director of the Department of Neurology at Campus Benjamin Franklin, Charité Berlin, Germany. Heinrich, as you know, has made seminal contributions to multiple aspects of stroke care. He has coordinated several projects in telestroke, secondary prevention, and hyperacute stroke care. He initiated the stroke emergency mobile STEMO, the results of which you have just seen being presented and integrated into this guideline, or mobile stroke unit project. And he's currently the chair of the ESO board of directors and a member of various ESO boards, including guideline committees. So today he's going to present on how to set up a mobile stroke program, challenges and opportunities. And Heinrich, we very much look forward to your presentation. So over to you.
Thank you, Martin. Also, thank you, Simona, for giving me or us the opportunity to share, so as one of the MSU groups, our experiences here in this webinar. So these are my disclosures. So you can see my financial disclosures in the table. Probably more important is that I'm the coordinator of the Berlin MSU program. And I'm also the current president of Presto, which is the pre-hospital stroke organization. So before we come to the challenges and the opportunities, I would like to talk about the effects of thrombolysis in different time windows. You all know about it, but I just want to make it visible. So I would like to refer to the placebo arm of the NINS trial. And even with placebo, 26% of the patients actually achieved a favorable outcome, so without disability at 3 months. If we treat patients in the late time window, so between 3 and 4.5 hours, according to the number need to treat given in the pooled analysis by Ken Lees and colleagues, we can save additional 7 patients from disability at 3 months. If we treat patients much earlier, so between 1 and 1.5 hours, we can save additional 15 patients from disability, adding up to 22 patients. And the question remained actually, because in the randomized controlled trials, eventually no patient was treated within 60 minutes. What would happen if we can treat patients within 60 minutes? And we have got data from the Berlin registry-based study. And if we extrapolate these results, actually, we can save additional 20 patients, so adding up to 42 patients from disability. And so this actually is close to a number needed to treat of 2. I think it's important when we talk about treatment within 60 minutes, which is also expressed as the golden hour, that we are not the first ones who talk about golden hour. Actually, traumatologists have taken this term for several decades. And when you read in Wikipedia, so the term was obviously originally invented by the French army during World War I. And very interestingly, a person we all know, but actually for her scientific merits, who was not a physician, Marie Curie, at the beginning of World War I, actually she put X-ray equipment on a Renault truck, and she herself and her daughter actually went to the front line, scanned thousands of patients, wounded soldiers, and trained technicians. So at the end of World War I, more than 20 of these, they were called Petit Curie, were in operation at the front line of the French army. So back to our mobile stroke units. As Silke already mentioned, Klaus Fassbender was the first one who described the concept in 2003, and also his group was the first one who invented or who implemented an MSU in Hamburg in Germany. A few years later, we had the opportunity to start an MSU here in Berlin. And so in 2012 and 14, the first cluster randomized trials were actually presented with time savings of 33 and 25 minutes. In 2015, the first MSU were implemented in the United States. And in 2016, it was the first already mentioned registry-based study that suggested improved outcome in patients if they were thrombolized on an MSU. And last year, actually, we had the two large intervention trials, also an additional one from Norway, showing improved outcome at 3 months. So when we implement an MSU service, I think we have two central aims. And one is to treat ischemic stroke patients as fast as possible. And the second is to treat as many eligible patients as possible. And the first one is actually aiming for better effectiveness. The second one is aiming for better efficiency. So there are always some basic questions. They are, so what is the right or the best setting for MSUs? What would be the optimal size of an MSU, equipment and staffing? So how can we ensure optimal dispatch quality? How can this be reimbursed? And finally, how can the processes be further optimized? So I think when I start with challenges, I would like to emphasize that we usually are neurologists or stroke physicians, and we are hospital-based physicians. And this means that we are usually not very familiar with pre-hospital emergency medicine. So we need advice and we need close communication with EMS professionals. They may actually fear that if they start a specialized ambulance for stroke patients, every discipline will come and say, okay, we need our own ambulance. We need to liaise with stakeholders. I think first we need to liaise with patients or advocacy organizations. Usually they are very interested in such an approach. Then we need to, of course, we need to approach public representatives, public politicians, and also health insurers who finally may then pay for the service. And of course, we need to liaise with professional organizations. I think our neurological societies had been rather skeptical at the beginning, but I think that has changed. And then I think we need to be very close to our crucial central partners, that is the dispatch center, then the EMS providers, and finally other hospitals in our catchment area, because they may be worried to be bypassed. So as we in the MSU see the patients first, we of course can decide where the patient goes, and that is a frequently expressed worry that they get bypassed. And then it comes to the setting, and many people think so an MSU service would probably be best placed in a very rural area because of the long distances. I would like to share my personal opinion and take so our geographical setting in the northeast of Germany. We are in close collaboration with a university hospital in Greifswald here in the northeast, very northeastern part of Germany. in order to cover 1 million people in this area, you would get very long distances. And if a patient in the western or southern part of the state of Mecklenburg-Vorpommern needs to be treated with an MSU, you would probably need around 2 hours to get to the patient, which makes it very difficult to save time. In contrast, in the metropolitan area of Berlin, with more than 5 million people, it's very easy to keep the MSUs busy and to see many stroke patients. Although, of course, the distances are very much shorter, but the most time we save is actually not distance related, but actually by avoiding handovers. I think there are two ways of dispatch. One is the standard way, which means simultaneous dispatch of a normal ambulance and the MSU. Both meet at scene, which means that actually usually the normal ambulance arrives first and the MSU second. And then there is the alternative, what we call the meet and greet approach, and which is, for example, practiced in Edmonton in Canada. Again, they use simultaneous dispatch with a first responder ambulance, but then the normal ambulance arrives much earlier. They take the patient and ship it towards the central area with the actually MSU already driving into its direction. Then they meet en route, take the patient to the MSU and examine the patient immediately. And as an alternative, the MSU can also be activated by the first responder ambulance. When it comes to the MSU architecture and equipment and staffing, I think there are always some common elements. We all need a CT scanner. We all need a mini lab. Most of the MSUs are actually connected via teleradiology to radiologists who then provide the reading. And as Silke already mentioned, we have specialized teams on board. And then there are very individual solutions that depend very much on the local settings. For example, if you are based in an old European city with narrow streets, you may prefer actually a smaller ambulance. On the other hand, if you want to do a lot of research on an ambulance, you may need more space. For example, our MSU actually has a radiation shielded chamber, as you see in the front of the ambulance, and all the lab equipment is placed here in this area as well. So this makes it very easy for us to do research in this setting. It also depends on the healthcare setting. There are many countries with physicians working in the pre-hospital area, but also countries without. And in these countries, actually, telemedicine can do a great job by replacing the stroke physician on the MSU. And then there are some local preferences. For example, in Melbourne, the entire MSU service actually is based on Mercedes Sprinter ambulances, and they therefore prefer such an ambulance. And as Silke actually showed you, there are so different variants. Choose your ambulance. If you want to use a full body scanner, you can, for example, you can use the Memphis ambulance, which is really rather big. As I already told you, dispatch is very important and probably actually maybe the most important issue. And we have just finalized a survey in the Bresto group that actually showed us that less than 10% of the dispatches finally result in intravenous thrombolysis. And there are many different dispatch algorithms in place in the dispatch centers. So some actually don't even have an algorithm. They completely rely on experienced dispatches. Some have locally developed algorithms, and some use commercial ones like the medical priority dispatch system. But one thing is actually very clear, that dispatches need training, and not only before you launch your MSU service, but also on a regular basis. And one aim is to raise the awareness of the dispatches for less frequent stroke symptoms. So this would increase the sensitivity. But at the same time, actually, they should avoid inappropriate dispatches, for example, by avoiding dispatches for patients with time already more than 4 hours from onset to dispatch, or patients with non-stroke symptoms. And you should be aware that, as everywhere, I think priorities are changing also in dispatch centers, so we need to raise this awareness again. Okay, here we are again. We have already prepared that in the Bresto group. Good, then we come to reimbursement. That, of course, again, depends on the healthcare system. Most of the current MSU services are still based on research funding or charity funding. In Berlin, we are getting reimbursement on a provisional regular care basis since 2016. So the final decision whether this goes to regular care has not been made. But there are negotiations on both sides of the Atlantic, and these negotiations are based, of course, on the individual study results, on the meta-analysis, which will be available over the next days, and now also, of course, on the ESO guideline, the first guideline on MSU, and also on cost effectiveness studies. So we have presented our incremental costs for per quality at the ESOC with 41,000 euros, and the results of the health economics analysis of the best MSU trials are also awaited in the near future. Sorry. Okay, so in order to get the processes optimized even further, I think we need appropriate documentation. In Presto, we have now prepared a minimal data set. Then we always should be aware that MSU is a team approach. So each of the team members actually needs training, and we have seen learning curves, and usually it takes a few weeks or even months to become very quick. Then we have the need of ongoing quality management, and I think the key performance indicators can be time metrics, stroke mimic rates, and symptomatic intracranial hemorrhages. We need to collaborate with the EMS providers in order to clarify how to handle cancellations, whether en route dispatch should be allowed or not, and how the normal ambulance teams should prepare the patients until the MSU arrives. And we need coordination with the hospitals. So in case a patient has already got a CTA on the MSU showing a large threshold occlusion, I think the patient should not go to the emergency department, but the patient should actually go directly to the angio suite in order to get immediate treatment. Good, and finally, I think there are huge opportunities straight ahead. The faster workup we can provide in MSU should also be beneficial for intracranial or intracerebral hemorrhage patient. We can start earlier blood pressure management. We can start earlier reversal of anticoagulation. We can use the MSU as a research platform. For example, on both sides of the Atlantic, we participate in the fastest trial examining activated factor 7. I think we get better understanding of the pathophysiology in hyperacute stroke, and therefore many of the groups are working with biomarkers. We can examine new therapeutic approaches like neuroprotective treatments or zonal thrombolysis during the transport. And as Silke already mentioned, we are developing alternative diagnostics based, for example, on ultrasound, microwave, telemedicine technologies. And in my last slide, I just want to again mention that MSU is a team approach, so we need to closely collaborate with many people. And I would actually thank our group here and the many others in Presto, and also Silke, who shared her experiences before, so in the preparation of this talk. Thank you.
Thanks. Thank you, Heinrich, for this excellent presentation and for sharing your experience. Really a great overview of challenges and opportunities of mobile stroke units. I can see already several questions in the chat. Please continue to raise your questions and we will address them at the end of the session. Now it's my privilege to introduce the second guideline. It's a joint ESO and ESMINT expedited recommendation on intravenous thrombolysis before mechanical thrombectomy. The presenter is Guillaume Turc, who chaired the guideline working group. Guillaume has extensive experience in guidelines and particularly in guidelines on acute stroke. He also chaired the ESO-ESMINT guideline on mechanical thrombectomy and the ESO guideline on intravenous thrombolysis. He is the current chair of the guideline board and professor of neurology at the University of Paris. Please, Guillaume.
Thank you very much, Simona, for the nice introduction. It is my great pleasure to present to you today the joint ESO-ESMINT expedited recommendation on intravenous thrombolysis before mechanical thrombectomy. These are my disclosures. Our module working group was chaired by Jens Filler and myself and was composed of 18 members, of whom 6 are neurointerventionalists. The key question here is, do we still need intravenous thrombolysis before mechanical thrombectomy in patients with large vessel occlusion? The main arguments in favor of direct thrombectomy are that intravenous thrombolysis is associated with low rates of successful reperfusion before thrombectomy. It can be associated with an increased risk of intracranial hemorrhage and thrombus fragmentation. It may delay thrombectomy, and it is also associated with substantial costs. Conversely, there are arguments in favor of bridging therapy. Indeed, a minority of LVO patients recanalize early with IVT. IVT may improve the rate of successful reperfusion after thrombectomy. Fewer recanalization attempts might be needed with IVT. It may reduce microvascular thrombosis, and it may be beneficial even in those patients with unsuccessful thrombectomy. As you are aware, several randomized trials have recently tried to address some of these questions. You are now familiar with our methodology of developing guidelines. We follow the ESO standard operating procedure, which is based on the GRADE approach. We identified 2 Pico questions. The first one was dedicated to the mothership paradigm, which corresponds to patients directly admitted to a center with thrombectomy facilities. The second Pico question was dedicated to the drip and ship paradigm, which corresponds to patients admitted to a center in which intravenous thrombolysis can be delivered, but not mechanical thrombectomy. We defined and rated the importance of outcomes of interest and performed a systematic review and meta-analysis before writing our recommendations. Expert consensus statements were provided whenever we felt that the available evidence was insufficient to provide evidence-based recommendations. Here is the first Pico question dedicated to mothership patients within 4.5 hours of symptom onset. It reads as follows: for large vessel occlusion, acute ischemic stroke patients directly admitted to a thrombectomy-capable center and eligible for both treatments, does mechanical thrombectomy alone compared with intravenous thrombolysis plus mechanical thrombectomy lead to a non-inferior proportion of patients with good outcome, which was our primary endpoint, and it was defined as MRS 0 to 2 at 90 days. This corresponds to functional independence. Does direct MT lead to a non-inferior or better results on other efficacy outcomes, notably reduced disability over the whole range of the MRS and successful reperfusion? Does it lead to a reduction in the risk of adverse events such as mortality and intracranial hemorrhage? Now let's have a look at the most important methodological point, the definition of non-inferiority. Our primary endpoint was the pooled unadjusted difference in the proportions of MRS0 to 2. Unlike others, we a priori decided to use random effects for our meta-analysis rather than a fixed effect model because of the relative heterogeneity in the design of the major trials. In order to predefine our non-inferiority margin, we conducted a secret ballot voting. Values proposed by module working group members for the non-inferiority margin range from 1% to a maximum of 5%. A majority of module working group members voted for a margin of -1.3%, which is based on a survey of US stroke neurologists. So you might not be very familiar with this kind of methodology. So what really matters and what you should have a look at is the lower boundary of the confidence interval. Here you see in the non-inferiority margin. Let's take the example of a study. And if you have a look at the lower confidence boundary of the confidence interval, then you see that this does not cross the line for the non-inferiority margin. And therefore, that study would demonstrate non-inferiority. That other study, however, would not demonstrate non-inferiority because, as you can see, the lower boundary crosses the non-inferiority vertical line. Our systematic review identified 6 randomized control trials comparing direct thrombectomy and bridging therapy in mothership patients within 4.5 hours of symptom onset. 4 of them have been published, namely DirectMT, DEVT, SCIP, and Mr. IV. The results of the 2 remaining studies, SwiftDirect and DirectSafe, have been presented at international conferences. 2 studies conducted in China met their predefined criteria for non-inferiority. Those were DirectMT and DEVT. Conversely, the 4 remaining studies did not demonstrate non-inferiority. It is also very important to keep in mind that all of the non-inferiority margins used in the trials were quite generous. Several trials use MRS0 to 2 as primary endpoint with an absolute non-inferiority margin of 10 or 12%. Other studies used the whole range of the MRS as primary endpoint with a relative non-inferiority margin. In DirectMT and Mr. IV, the lower boundary of the confidence interval for the common odds ratio for reduced disability had to be at least equal to 0.80 to claim non-inferiority. We judged the overall risk of bias to be low for all but 3 randomized trials. In DirectMT and DEVT, the median door to IVT time was very long, approximately 1 hour. A selection bias is also possible because the Chinese healthcare system requires initial self-pay for alteplase. Crossover between treatment arms was also observed in DirectMT. Finally, in SCIP, more than 20% of patients in the bridging therapy arm had arterial puncture before IVT was started. These are the results of the meta-analysis for our primary outcome, MRS0 to 2, which corresponds to functional independence at 3 months. As expected, no study demonstrated the superiority of either treatment. Across trials, the risk difference ranged from -8.5% in SwiftDirect, which therefore tended to favor bridging therapy, to 7.7% in DEVT, which tended to favor MT alone. Now let's have a closer look at the pooled results. The unadjusted risk difference was -1.9% with a confidence interval of -5.9 to 2.1%. Non-inferiority was also not met based on the minimal clinically acceptable margin of 5% proposed by module working group members. Therefore, according to our own predefined criteria, we cannot conclude that direct MT is non-inferior to bridging therapy. When considering reduced disability, the adjusted common odds ratio was 0.92 with a confidence interval of 0.80 to 1.07. These are the results for all-cause mortality at 90 days. This was similar in the two treatment groups with an unadjusted odds ratio of 1.06. Here we have the results for successful reperfusion, which was defined as MTK 2B or better, which corresponds to a reperfusion of at least half of the target arterial territory at the end of the endovascular procedure. You can see here that bridging therapy was statistically superior to direct MT with an unadjusted odds ratio of 0.72. Regarding symptomatic intracranial hemorrhage, there was a trend for a lower risk of ICH with direct MT, but this did not reach statistical significance. However, when considering any intracranial hemorrhage, direct MT was significantly superior to bridging therapy with an unadjusted odds ratio of 0.80. This is our evidence-based recommendation for the 0 to 4.5 hours time window. For patients directly admitted to a thrombectomy-capable center for an acute ischemic stroke with anterior circulation large vessel occlusion and who are eligible for both treatments, we recommend intravenous thrombolysis plus mechanical thrombectomy. We judge the quality of evidence to be moderate, and we provide a strong recommendation. Both treatments should be performed as early as possible after hospital arrival. Mechanical thrombectomy should not prevent the initiation of intravenous thrombolysis, and intravenous thrombolysis should not delay mechanical thrombectomy. We found insufficient evidence to provide an evidence-based recommendation for patients with wake-up stroke. Therefore, we provide the following expert consensus statement. For patients directly admitted to a thrombectomy-capable center within 4.5 hours of symptom recognition after wake-up stroke caused by anterior circulation large vessel occlusion, we suggest intravenous thrombolysis plus mechanical thrombectomy. The selection criteria, but this only applies to selected patients. The selected criteria are detailed in the corresponding European guidelines, namely the 2019 ESO ESMINT guidelines on mechanical thrombectomy and the 2021 ESO guideline on intravenous thrombolysis. Notably, eligibility imaging criteria for IVT include either DWI flare mismatch or perfusion core penumbra mismatch, according to the extent trial criteria, which are listed here. Now let's focus on the second Pico question, which is dedicated to drip and chip. Other than that, it is identical to the previous one. Unfortunately, the literature on this topic was scarce and we had to rely on a systematic review of observational studies. In the interest of time, I will directly present our evidence-based recommendation. For patients admitted to a non-thrombectomy capable center for an acute ischemic stroke with anterior circulation large vessel occlusion and who are eligible for both treatments, we recommend intravenous thrombolysis followed by rapid transfer to a center with thrombectomy facilities. We judge the quality of evidence to be low, but this is a strong recommendation as well. Importantly, intravenous thrombolysis should not delay the transfer to a center with thrombectomy facilities. Here is the expert consensus statement for wake-up stroke patients according to the drip and ship paradigm. This recommendation is identical to the one for mothership patients. We suggest intravenous thrombolysis plus mechanical thrombectomy in patients selected with advanced imaging. Now, let's discuss our recommendations. We are aware that another guideline group might actually come up to an opposite conclusion based on the same data. Indeed, everything relies on the choice of the non-inferiority margin. Some might consider that 1.3% is too stringent. However, non-inferiority was also not met based on the maximum acceptable margin of 5% proposed by MODI working group members. Only accepting a margin of 5.9% would lead to the conclusion of non-inferiority. And therefore, the question here is this really acceptable? This would correspond to 59 fewer independent outcomes among 1,000 patients treated with direct thrombectomy. And the corresponding number needed to harm would be 17. One must also keep in mind the effect size of previous guideline changing trials. In Mr. Clean, this unadjusted risk difference for MRS-022 was approximately 13%. In the NINS TPA trial, 12%. In Extend, 6.7%. And in AKS3, it was 5%. Let's conclude. It needs to be borne in mind that randomized trials only included patients with anterior circulation large vessel occlusion strokes, eligible for alteplase within 4.5 hours of symptom onset, and admitted to a thrombectomy capable center. In that setting, non-inferiority of direct MT has not been demonstrated according to our pre-specified non-inferiority margin. Therefore, in the absence of contraindication, we recommend IVT before MT, even under the mothership scenario, which is less favorable to IVT than the drip and ship scenario. However, IVT should not delay MT or the transfer to a center with MT facilities. We also suggest IVT before thrombectomy in selected patients with wake-up stroke. These recommendations may be updated in case individual patient data meta-analysis disclose subgroups of mothership patients in whom direct MT is superior to IVT plus MT. This could lead to more personalized treatment strategies, which will be the topic of the next talk. Thank you very much for your attention.
Well, yes, and thank you very much to you, Guillaume, and to the entire working group for presenting this guideline. Very clear recommendation also. And thank you also to our colleagues from ESMINT for working with ESO on that guideline. It's now a pleasure to introduce Dr. Raul Nagera, an internationally renowned stroke expert. Dr. Nagera recently moved from Emory to Pittsburgh, where he is the director of the UPMC Stroke Institute and endowed chair in cerebrovascular medicine. Raul is going to speak about the future of intravenous thrombolysis before mechanical thrombectomy towards precision medicine with a question mark at the end. So Raul, we very much look forward to your presentation and discussing this question with us. Thank you very much.
Thank you very much, Martin. Thank you, Guilherme, for giving such a nice introduction to our discussion here. So we have this big dilemma as to whether go direct or to bridge, and that's what is going to be discussed here. So here are my disclosures. So again, direct or to bridge. Let's dive into the past. The neuroendovascular treatment tends to follow the footsteps of cardiology. This is a question that has been addressed by our colleagues, and when they look into facilitated PCI, meaning PCI with the use of reteplase plus minus glycoprotein 2B3 inhibitors, there was no benefit in the adjunctive treatment with the intravenous drugs in relation to the endovascular treatment alone. However, it's important to acknowledge that they face much more frequent and atherothrombotic issue versus us. We have embolic issues in over 90% of the cases, specifically in this side of the world. The past enforces that the use of intravenous thrombolysis should be performed in every single situation that the patient is candidate, and this applies to both the ESO ESMINT guidelines and the AHA guidelines with the highest possible level of recommendation. But now you have the present. And before you discuss this data, right, these trials, I think one of the most important things that we need to highlight is that these data, they are not applicable to most settings. What you are talking here about to bridge or to direct MT, okay, it only applies to very specific scenarios. It's a scenario of a thrombectomy capable stroke center that, by the way, has a fast workflow and the team is immediately available to perform the procedure. So these studies, these data, these guidelines, they do not apply to any primary stroke centers. They do not apply to any thrombectomy center that doesn't have a fully optimized and fast workflow. And they do not even apply to well-oiled machines, very fast, good work centers, if the team is not immediately available. At 2, 3 in the morning, when you still have to mobilize the team, patients should unquestionably receive intravenous thrombolysis. So under all these conditions, we must continue to provide intravenous thrombolysis to our patients. The other consideration, when you touch on this towards the end of the talk, is that these data only apply to alteplase, right? So the question as to whether you should bridge with TNK, whether that's actually superior to even alteplase or direct, remains to be answered. So we start with 3 trials in Asia, and they tend to show non-inferiority. When you first look at the data, there are many nuances there. Then you have the MISTRA-CLIN, no IV trial. Some meta-analyses were conducted, not at all patient level type of meta-analysis, but you can see that this initial meta-analysis, and here there are 2 of them, had pretty neutral results, right? And depending on what you consider your non-inferiority margin, many people start to question, well, maybe the EVT is non-inferior to bridging. But then our colleagues from Swift Direct and Direct Safe actually said not so fast. So very recently in the ESOC, we had these 2 presentations. But even before that, it's important that we step back to, again, as Guilherme talked about, we have to understand this concept of what is the minimal clinically important difference, which for functional outcomes, specifically 90-day MRS 0 to 2, we actually consider difference as low as 1 to 1.5 or at most at 5%, very significant, right? So these trials adopt non-inferiority margins that were in the range of 20%, okay? So we have to first understand that very well. But then when you actually add the data from Swift Direct, as it was presented here, you can actually see that nominally outcomes were actually better with the bridging therapy than with direct MT, with a difference of 7.3%. You can see that the lower limit of the one side, 95% confidence interval, was minus 15.1%. When you look at secondary outcomes, there are some issues of interest here. The reperfusion was higher with the bridging therapy, but so was the rate of symptomatic intracranial hemorrhage. So good on one side, bad in another side. When you look at direct safe, the Australasia trial presented by Peter Mitchell and Bernard Young at the same conference, you can see again that normally the outcomes were actually better with bridging, although not statistically significant. There was, essentially a 6% difference here. And in terms of secondary outcomes, unlikely Swift Direct, you didn't really see any differences, including the rates of final reperfusion or the rates of symptomatic intracranial hemorrhage, although numerically a little higher with bridging, as should be expected. Guilherme has now presented the better meta-analysis, the update meta-analysis, which actually comprises out the 6 trials that have been performed, again, without the place to date. And again, when you look at the lower non-inferiority margin here, 0.79%, it looks like we are far from unequivocally proving that direct is non-inferior to bridging prior to thrombectomy. So not surprising, you have this, again, strong recommendation based on moderate quality of evidence to continue to offer intravenous thrombolysis to all patients who present to a thrombectomy capable center within the first 4.5 hours. Other than the data and what it has shown, which again, maybe better recanalization actually with bridging, maybe not, maybe a little more hemorrhage with bridging, maybe not, but the outcomes tend to be either the same to potentially better with bridging. And even in trials that didn't necessarily show higher reperfusion. And perhaps we are at a time now that you have to depart from this concept of the macro vasculature, which is what we see in an angiogram after our treatment, to better understand what happens at the micro circulation, right? And there is a paper that I think it's very thought-provoking recently from our colleagues from Barcelona, from Mark Ribos's group, where essentially what they demonstrate here, as you can see, even in patients with TK3, there are residual perfusion deficits. And these perfusion deficits seem to be more substantial when you have more passes. Okay, so even though you are achieving macro recanalization, you are having issues with micro reperfusion deficits. This actually is a well-known phenomenon in the coronary bed that has been named no reflow. And I think that's one of the potential advantages of intravenous thrombolytics, other than just this idea of pre-procedure or even post-procedure macro reperfusion that you keep looking for. Maybe there's one of the reasons why the outcomes are better with bridging than with direct thrombectomy. And one thing that I find very curious is we know a lot about this no reflow phenomenon from the coronary bed, right? But it turns out that this name was actually coined after studies, animal studies dating back to the 1960s, as you can see here, were done in the cerebral vasculature. So the non-reflow phenomenon was first characterized in the cerebral vasculature. And I think we should stay tuned for the complete trial. It was a very provoking trial, centered in Spain, where the investigators actually give intraarterial alteplase after achieving complete or near complete reperfusion, which seems very counterintuitive, right? Maybe you're just adding the risk of reperfusion hemorrhage. But again, the idea here is, can thrombolytics actually help us in the microcirculation, things that go beyond what you see at our final post-procedure, post-thrombectomy angiogram. So I'm very curious to see these results, and I think this idea of non-reflow is a concept that you need to start embracing in cerebrovascular medicine and start exploring this concept more and more. Moving now to my hope for the future, right? My hope for the future, and I'm not so sure you are there yet, is the idea that you're gonna depart from this polarized world that you live now, not only in politics, but also in medicine, where you're practicing this very dichotomized decision-making based on algorithms and guidelines, cookbook medicine, really, to understand that life is not really black and white. You have all these shades of gray, and you have to practice not the cookbook medicine, but rather a more individualized precision type of medicine where you individualize care. This is a concept that Dr. Lou Kaplan has been talking about for over 3 decades now. And he first spoke about this in terms of TIA. You have to understand what's wrong with our specific patient and look at that in the context of the overall data and literature. Perhaps you can bring that also to this issue of to bridge or not to bridge. So in the area of precision medicine, I think the question should not be, should we or should we not be giving intravenous thrombolysis to all eligible patients who present to a thrombectomy capable center prior to endovascular therapy? It's not the right question. This is a population-based question. The better question is, who are the specific patients who should versus should not receive intravenous thrombolytics when they present to a thrombectomy capable center, right? Is living from the concept of clinical trials and data that really analyzes population only to try to bring the patient characteristics and help us with the decision-making process. Georges and I wrote a little bit of a critique about all these trials that were emerging last year. I would invite you to review this paper. Here, what you try to do is trying to identify some factors that may sway you more towards doing a direct approach versus a bridging approach. I think we know there are factors that will define higher versus lower chances of reperfusion or benefit after intravenous thrombolysis, okay, as well as complication risks. There are peri-procedure issues that you need to consider in terms of the need of intra or extracranial stent in this patient population. There are also geographic and center-specific characteristics related to the cost of therapy or the speed of your local workflow, the availability of your team at any given time. Again, if your team is not in-house, there is no sense to have even a discussion about this. You have to bridge because time is brain. With the idea of exploring some of these individualized components, patient characteristics, we perform a pool analysis at individual level of the DVT and SCIP trials. You present this a year ago at the ISC. We call this the SHRINE pool analysis. In terms of outcomes, pretty neutral. There was no major difference. A little bit more any intracranial hemorrhage in patients with bridging, also a little more puncture site complications in patients with bridging, not surprising. But in terms of outcomes, even though you were analyzing two trials from Asia before the trials that actually had better workflow, right? As you know, in Asia, you had some issues with the workflow, specifically the door to needle time, right? And I think we have always talked a lot about door to needle time and door to puncture time. We are now getting to this new area where you have to understand the importance of the needle to puncture time, because the needle to puncture time is exactly the period that will give your intravenous thrombolytic an opportunity to work. So if you are centers, and this really happened a lot in Asia, where the door to needle time was relatively delayed for several logistical reasons, but they actually had very good door to puncture time, the needle to puncture time was short. And this is one of the potential reasons, okay, along with the fact that the Asian population probably has more intracranial atero, and intracranial atero may be more resilient to intravenous thrombolytics, while you see a little bit of a dichotomy between the Asian trials and the trials done more recently. But going to the results of this, we actually adopt a non-inferiority margin that was 0.85, so pretty, actually pretty liberal. And even at that point, you almost got it, but it was a 0.84. So we failed to show non-inferiority, even though you were using pretty liberal numbers here. But what I'm more curious to know about these trials is actually, again, not the overall population data, but can we dissect the different populations that may benefit versus not from the different approaches? And here we have some initial data that it's quite exciting. When you look at onset to puncture times, okay, it looks like if you have your onset to puncture less than 3 hours, you're better off with bridging, versus if your in-situ puncture is beyond 3 hours, you may do better with direct MT. And the reasons for that is not only you have more penumbra, right? As you when you were earlier, this would apply to any type of revascularization, but you know now more than ever that not only you save more penumbra, but you actually reperfuse more with intravenous thrombolytics the faster you treat the patient. So I think this is pretty consistent with what I expect, and maybe time to treatment may be one of the differentiators you may be using in the future to decide as to whether or not you bridge. But again, this requires further validation from large data and in broader population. Another piece of data that I thought was very exciting is that the patients that had intracranial ICA occlusions, they did a lot better with direct MT, right? These are patients that have typically a lot more clot burden. We know that TPA for intracranial ICA occlusions, they only recanalize about 4 to 8% of the patients. So perhaps as a population that, again, pending confirmatory data, we may skip TPA prior to thrombectomy. In terms of SICH, symptomatic intracranial hemorrhage, one of the things that you notice is patients who had atrial fibrillation, okay, they perhaps do better, okay, if you do bridging, because if you don't do bridging, if you do direct, because atrial fibrillation seems to increase the risk of intravenous TPA-mediated hemorrhage in this population. Again, can see a remarkable interaction term here, but we await for confirmatory data from the larger meta-analysis, but maybe AFib is a differentiator, as you can see here, also in terms of mortality. Whereas if you have atrial fibrillation, maybe you want to go direct versus not, you then would go with a bridging therapy. So stay tuned for the big meta-analysis. Here you just had 2 trials, Asian trials, numbers that were relatively small, it's just around 500 patients. The improving reperfusion strategies in ischemic stroke or IRIS meta-analysis is ongoing, and I think it's really gonna help us better understanding if we can adopt this approach of more individualized decision-making for this specific topic. Finally, I think it's very important that you understand that these data, they were actually outdated from the start. One of the things that was striking to me is in April 2018, we already knew that bridging with TNK was very likely superior to bridging with alteplase, right? You had better recanalization rates. You even had a suggestion of better outcomes with a P of 0.04 when you look at the median scores on ordinal analysis. So it was a bit unfortunate that we start out these trials using alteplase, even though you had this knowledge. So I think there is a need now to explore the same paradigm using what we all believe might be a better drug for bridging than alteplase. We have one of these studies just started in Brazil. It's called the Resilient Direct TNK. It's done with our Resilient network in Brazil, and I suspect that many other colleagues will join us on this. So to conclude, direct thrombectomy has not been unequivocally demonstrated to be non-inferior to bridging therapy. Therefore, intravenous thrombolysis should continue to be offered to the vast majority, if not all, mechanical thrombectomy patients presenting to a thrombectomy capable center. However, it's important to acknowledge there are many individual variables in the decision-making process that we have access to that cannot be properly considered in clinical trials. So it sounds reasonable to adopt a tailored, individualized approach, mostly if the results of the IRIS analysis confirms that this approach makes sense. Finally, the big question remains, how about bridging with TNK? Thank you very much for your attention. I'll be glad to take any questions.
Thanks. Thanks, Raul, for this really insightful overview and for sharing your opinion on the future of acute stroke treatment. And now it's time to move to the Q&A session. Two experts are joining us for this session. We have Georgios Tsivogoulis. Welcome, Georgios. He's the co-chair of the Guideline on Mobile Stroke Unit, professor of neurology in Athens, and vice president of the ESO. And we have also with us Jens Filler, who is the co-chair of the expedited recommendation on direct thrombectomy. Is the director of the interventional neuroradiology in Hamburg and the current ESO ESMINT president. So welcome everyone. We have less than 20 minutes and many questions to answer. So we can start. The first question is for you, Georgios. So it comes from Stefano Ricci from Italy, and it's about terminology. Maybe the term MSU is a little bit misleading. After all, stroke unit care is much, much more than CT scan and thrombolysis. What do you think?
First of all, I think that this question is not related to our guideline, but my personal opinion is that the terminology is very appropriate because also blood pressure management has been implemented in all mobile stroke units, and we have important information with terms of CTA that can bring our patients directly to the angio suite. So I don't think it's all about thrombolysis, and I think that the term is appropriate.
Thank you.
Yes, there is, Simona, there's another question, and that actually goes to Heinrich or Silke. And the question was, is there some kind of a contingency plan about the MSU having a vehicular collision? Again, that is not related to the guideline itself, but it's probably of interest to the audience. Heinrich.
I think Silke is probably even more competent because she actually writes an MSU, so she should know.
Wonderful. So Silke.
That's an excellent question. Well, that is a very difficult question. As long as these ambulances are funded just purely from research money, that is quite difficult to have a second one if you don't have enough funding to start your service with more than one ambulances. But very, very correct. I think once we've got more evidence and once we've got all these new future trials which add more data, it's all about money in the end, who funds what, and then of course there could be a backup plan available.
Thanks.
Let me just add, so to my knowledge, actually there have been two rather severe accidents with mobile MSUs, one in Houston very recently and one in Berlin a few years ago. Fortunately, no patient was injured. In our case, actually, the doctor had a moderate injury. But I think you're completely right that we should have SOPs in place, what we do in such a case.
Thank you. One question about the expedited recommendation. It comes from Brian McGrory. It's directed to Jens. Does the strength of the recommendation for the bridging thrombolysis differ based on the size of vessel occlusion?
Yes, excellent question. So, so far we don't have a patient level analysis, but it's something that we would expect to have some differences here. And Raul already indicated that in the SHRINE analysis, there was a very good effect of direct thrombectomy in very proximal occlusions. But the recommendations do not differ at this time. But as soon as we have a patient level analysis from all the studies, I would expect that there could be some indication in this direction, but not at this moment.
Well, yes, and then I guess there is a question now, maybe to Raul, but also to Jens, that's from Vincius Montanaro. Should artificial intelligence methodology be more used in addressing the question of precision medicine and predicting which patients should receive bridging therapy? I realize, again, this is not immediately related to the guideline, but still it seems people are interested in this. And maybe you want to comment on that.
I think certainly is one of our hopes that AI will help with this type of decision making. Oftentimes it's just very hard, again, because at least in randomized clinical trials, you can get to the finesse of the details that you actually have access to when you are seeing these patients in clinical practice. So one of the issues here is, in order to come up with a good AI algorithm, you actually need probably more data than you are capturing through the randomized clinical trials.
Yeah, I think just to add a few words more, I think it's really challenging to have sufficient training data to identify a differential effect of IV TPA plus thrombectomy alone. And but this is certainly something that's going to come, but it needs a bit more work than can be done in a few weeks.
Thank you. Silke, one question for you. You have a broad experience on the mobile stroke unit. What happens if the patient presented together with acute myocardial infarction and ischemic stall? Still, you do consider the pre-hospital IVT?
Yeah, that's a good question. Well, that actually can happen, and it all depends whether you've got an ST elevation infarct. What I actually would do is, of course, with an additional stroke, I would speak to the cardiologist, to the interventionalist, and I'm pretty sure they would be in favor for thrombolysis, and then we would do that. But you would then transport the patient, rather than going to the next stroke, and you would then take him to the cath lab that he gets his cardiac PPCI treatment.
Then there's a question for the IVT group again. You discussed the non-inferiority margin, but the question is, and this is from Walid Butt, what do you actually consider an appropriate minimally clinically important difference with regards to establish non-inferiority in bridging versus direct MT paradigms? And also maybe, Raul, you want to comment on that, since you also seem to have an opinion on that. So maybe, again, Jens and Raul.
Yeah, so I think Guillaume did a very good job with explaining this whole non-inferiority problem. And we had, in fact, this was most of the most interesting parts of the whole guideline process, this discussion, what's the difference that we are talking about. And yeah, obviously it's a matter of opinion, one, and also a matter of money, two. So what do we accept? So I think the general feeling is more than 5% difference is not acceptable. And this is now with the data that we have, it's beyond that. So we are kind of safe with our recommendation, but we were not very united within our group about the selection of 1.3%, but this comes from a larger independent analysis. And I think that's currently the opinion, 1.3% for cerebrovascular conditions. Yeah, but we could talk at length about this problem. This is a very serious question.
Raul?
I agree that definitely 15 to 20% is unacceptable, right? You can't risk denying a treatment if there is such a high likelihood of a benefit that you may be negating to patients. So I would think that 5%, it's probably the highest number I would consider. I think somewhere around 3% or so, it's probably what I would like to see. I think this, again, needs to be individualized, right? So there are places where intravenous thrombolytics are very expensive, places where it's a lot cheaper. And it happens to be that in the places where it's more expensive, specifically United States, okay, thrombolytics are about 10-fold higher price in United States than in many countries in Latin America, right? These are also the places that had much better EVT workflow. So if you have a faster EVT workflow, you're gonna decrease that needle to puncture time, give thrombolytic a lower chance, right, of working, and you are paying more. So I think depending on where you are, how much you are paying, how good is your workflow, this minimum clinically important difference should vary. Again, it's the whole idea that one size doesn't fit all. You need to individualize your local reality, your local data to your actual expectations. But definitely anything that it's higher than 5%, I wouldn't consider acceptable.
Thank you. I can see that there are several questions in the QA chat about the thrombus characteristics. Do you think that clot imaging may impact on treatment decision?
I think this is a fascinating question. It's a question that we have done a fair amount of research on. So for the broader group who's less familiar with this, there is good data, one from the Astra trial, essentially suggesting that patients that have blooming artifact on MRI, and you get blooming when you have more iron with erythrocytic red blood cell rich clots, right? So those patients, they tend to actually respond better to endovascular therapy, but also to intravenous thrombolysis. We have data from our center with dense vessel sign. There is data with dense vessel sign also for intravenous thrombolysis. So both blooming and dense vessel sign, which are likely indirect signs of high erythrocytic content, tend to respond better to both intravenous thrombolysis and thrombectomy. I actually have that list in that table that I show very quickly. As you know, if you have a dense vessel sign, if you have blooming, chances are you have a higher likelihood of success with thrombolytics. So it should, if anything, sway to give you to give the patient the bridging therapy. So I believe there is some data to suggest that, but it's not very strong. The other consideration is you're now embarking in a potential new age where you're going to be taking patients direct to angiography. As you may know, there are a couple of trials ongoing now for this. So this question may become irrelevant if you demonstrate that in the first 4 or 6 hours, you should be taking patients straight to the angio suite, because we're just not going to have that data.
Thank you so much. People in the chat seem to be interested, and this is a question for Jens and the group again, the guideline group, in the time dependency of the decision to use either combined therapy or mechanical thrombectomy alone. And Raul, in his presentation, also briefly showed data on 180 minutes below and above, indicating a potential differential effect here of the timing. What was the conclusion of your guideline group regarding the potential time cutoff in terms of timing, and what future research needs to be done in that area?
Yeah, this was another very important subject to discuss. So generally, the guideline is for the recommendation is focused on the time window 0 to 4.5 hours, because all 6 studies only included patients within the first 4.5 hours. And we also include wake-up patients into our recommendations based on an expert recommendation. But we, on purpose, we didn't include the patients within the 4.5 to 9 hour time window that was partially covered by some other studies that you are well aware. And so we felt that the information that is actually available on the 4.5 to 9 hour time window is not is not complete enough to make a recommendation here. So this requires some more study, I'm afraid. And within the first 4.5 hours, I think we just don't have enough data. So there is a lot of thinking about this, and as Raul mentioned with this thrombus imaging subject, but this is more hypothesis generating data than something that we can actually recommend.
Thank you. One last question to Georgios. There is someone who probably is not very enthusiastic about mobile stroke units and asks how widely applicable are these mobile stroke units?
The application is gradually widening, and I think it's a matter of cost effectiveness. We're very eager to see the cost effectiveness analysis from Best MSU and be proud. And I think that as we have stated in the discussion of our guidelines, the final decision will be to the political stakeholders to implement this new model of therapy. And I think this is based on how much is valued in terms of saving years of disability. I think that the effect is homogeneous and very strong in terms of improving functional outcome.
Thank you. Thanks, Georgios. We have many questions in the chat, but unfortunately our time is over and we have to close. I think it was really an amazing session and an amazing discussion, and I wish to thank all our discussants for joining us. I'm now handing over to Martin for some closing remarks, but as first I wish to take this occasion for thanking him for making guidelines one of the flagships of his presidency and for his proactive and continuous support to all the guideline board activities. Thank you, Martin, and please close the session.
Well, yes, thank you, Simona, and thanks to everybody for joining. Thanks in particular to all the speakers, the presenters, and the discussants, and of course, again, the guideline working groups. It has once more been a wonderful session. You have probably realized that we are now going to have these webinars more regularly. The next one is scheduled for March 29th. That will be, and you see it here on this slide, a guideline webinar on women and stroke. You also see that we have announced again the ESO conference in Lyon, which is running from the 4th to 6th of May. And I can tell you already that we took the decision this week that this conference will be in person. So please register. And we all really very much look forward to seeing you there and meeting in person. We've been waiting for this for a long time. Also, you see here the barcodes for the different guidelines. They should take you directly to our website. Also be aware that these guidelines will be published on Magic App, that the slides will be made available, that we will make those guidelines available through our journal. That will happen very soon. And also one of those will be available at the ESMINT journal. And again, stay with us, bear with us, have a wonderful rest of the day from wherever you're watching this. And I can tell that we have more than 1,500 people registered for this webinar. It will be still available on demand, and enjoy the rest of the day. Thanks for joining. Bye-bye.